Well, hello dear viewer, and karibu sana once again to one of the health topic that we will be looking at this evening, where we are looking at orthopedics, of course just issues to do with the bones and the muscles, and narrowing down to how you can manage that lower back pain. So of course this is coming to you courtesy of the Presbyterian Church of East Africa Health Week, that is derived, or the theme of this year is derived from Jeremiah 33:6, that is Jehovah will restore my health. And of course we've been partnering with all the Presbyterian Church hospitals, that is Kikuyu Hospital, Tumutumu Hospital, and of course PCEH Ogoria Hospital, just to bring you these particular health topics, or just to create awareness about different health problems or health issues. So this evening we are looking at how to manage that lower back pain. Of course in studio I am with an expert, and together we're just going to understand more about this, and of course the most important bit is where we are going to provide solutions to you. So Daktari, karibu sana.
Thank you, Aida. I'm happy to be here.
Just feel free to introduce yourself to our audience this evening.
Right. So my name is Dr. Jacqueline Mwema. I'm a registrar in orthopedics working in PCA Kikuyu Hospital.
All right, and thank you for your time, and of course we look forward to learning from you. Let us just start, of course, now with the basis of this, or the basics of this, by first of all just understanding how the back looks like. Yeah.
So, because the focus of today, we're going to talk about the lower part of the back. So that's basically the lumbar area.
Okay.
And the back, basically up from the cervical spine, that's at the neck area, to the lower lumbar area, consists of bones and discs in between. They're called intervertebral discs. So the discs normally act as shock absorbers to your back and make you, because if the back was just mainly containing bones, first of all you'd be heavy and you wouldn't be able to be agile to flex or move around. So they act as joints and shock absorber of your back. So basically that is the bony anatomy of your spine, of your lower spine. So back here, this is the front part of your back where looks towards your stomach. And then the posterior aspect of it, this is where your muscles attach. The muscles in your back, which normally help you to flex so that you're able to bend forwards, sideways or backwards. They normally attach to the back surface of your back. Now another important thing to note is that you have nerves that come from your spinal cord. Your spinal cord runs behind the bony part, the anterior bony part of the spine, and they come out like twigs from a main branch, coming out in strands. Those are the nerves that go to your legs, supplying your back. So as we'll come to talk today, we'll understand that the importance of the position of the nerves and the position of the disc, because that's one of the major causes of our pain. You'll understand how it actually causes the pain based on their location, how close it is to the intervertebral discs. So basically I think that is the major part of anatomy for the lower spine. So the lumbar area normally attaches to the lower part, which is the sacroiliac. This is the where you normally sit on, but this is not our focus today. Today we'll focus on the lumbar spine. Yes.
All right, and thank you so much for that. So of course with this it's much easier for our audience to understand as well. So having talked about that, how would you say like lower back pain, like the problem is prevalent, let's say just in our society, and even as we look at now the issues of age, who are more affected? Yeah.
So low back pain is actually one of the most common conditions that will take a patient to see a doctor. It's actually second to respiratory tract infections. So about 50 to 80% of our population at one time or another in their lifetime, they'll visit a doctor due to low back pain. And commonest causes are in our setup. Basically, commonest cause of low back pain is muscular strain. We've talked about the attachment of the of the muscles in the posterior part of the back. So just how you can sprain your ankle, you can sprain your wrist, you can also sprain your back. And that in itself can cause a lot of pain, because it what I did mention is that normally your spine has a nice curve. It's called a lordotic curve. But then when you have muscle strains, like the muscles are quite rigid, so it makes your spine very straight, very rigid. So meaning any kind of motion you have will cause pain. When you try, especially when you try to bend, or any motion you try to have will cause pain. So 80% of low back pain are usually due to muscular sprain. Now, what risk factors do we have to cause muscular sprain in our back? Basically, it's the activities we do.
Okay.
So activities that involve bending or sitting for a long time, maybe in a seat that does not help with the curvature we've talked about, or heavy bending for too much. You know, ladies especially, that's why low back pain is very common in ladies, because of the activities we do in the house, in the home, the household chores we normally do, the cleaning the house, we have to bend, the washing, doing your laundry and all that. So that's why it's very common in ladies. By the time you're about 27 years of age, the agile, springy nature of your back muscles cannot tolerate the activities that you could do when you're young. The bending, the standing for a long time, the sitting for a long time. That's why we advocate by the time you're 27, you need to adjust how you do your activities. Okay. Also, obesity is also another major cause of low back pain. That's why when you see a patient in clinic with low back, one of the criteria you tell them is you need to lose at least 5% of your body weight to help improve your symptoms. Other things are like smoking, drinking. There's also a small thing about work, like when you're not motivated by your job. I don't know, it's a psychological aspect to it. Okay. Yeah, but it can also, it's also a risk factor for low back pain. Now, there are these things called red flags. What I haven't mentioned is also age, degeneration. Degeneration can also cause low back pain, which is acceptable, because any joint in your body can undergo degeneration, and that in itself can cause low back pain. Okay, by degeneration you mean? So we've talked about the anatomy of the spine. So the discs, the intervertebral discs, the ones I talked about being the shock absorber of your back. By the time you're around 29, it's normally, so when you're young, it's normally nice and cushiony. It has water content and innervation. It has some nerve supplies to the edge of it. But as you age, just like how you wear your shoe for a long time, it's your sole degenerates, such that it becomes old, worn out, basically. So the same thing can happen to your discs. So it loses the water content and it shrinks, making it easy to move within the space allocated here. So that's what's called degeneration. It just loses the water content, what makes it cushiony when you're young, and then that in itself can cause pain. So this is from the time you're 29 as you progress. I'm not saying it's a linear acceleration, how you degenerate, but basically starts around that time. Yes. Okay. Now, before we proceed, of course, to now the next step that you wanted to speak about, you've spoken of all these, like the risk factors and probably the causes of these. Are there conditions or diseases that might make one's lower back pain, other than the pain, other than the age? Will you say we have any other conditions that probably will make the lower back to experience that pain? So one of the commonest diseases that's normally associated with low back pain is like diabetes and rheumatoid arthritis. Diabetes, mostly the type 2 diabetes, because normally associated with the bigger body habitus, like the patients are on the bigger side. And rheumatoid arthritis because it affects many joints in your body. So they normally, such patients are normally hard to manage, but yes, it's one of the risk factors for low back pain.
And you also spoke of like the veins, how the veins now go to the other parts of the body. Does this mean that when probably I start experiencing, or someone starts experiencing lower back pain, this might transmit or just go to other body parts?
All right, so what I was talking about is the nerves that come from the spinal cord. The spinal cord normally runs from your up from your cranium, that's your head, from your cervical spine down up to the around. It normally terminates at around your first lumbar vertebra. Then from the first lumbar vertebra going down, it's normally like strings of nerves. It's called cauda equina, like it's like a horse's tail. That's what it means, cauda equina. So once you have a disease of your disc, once you have what we'll talk about in a few, disc bulge or a disc prolapse, such that the disc comes behind to compress your nerve, like back here. So you will feel the pain along the distribution of the nerve, because this nerve that's coming from your spine is going somewhere in your leg, either to your thigh, to your leg, to your toes. So whatever nerve is affected, depending on the region, you have something called the radicular pain. So you'll have the pain and numbness along the distribution of the nerve. Yes.
All right. Now, you wanted us now to look at now the telltale signs, because of course with many of these conditions, experts will always be like early diagnosis, of course, will always like assist in the management and treatment of this. So with lower back pain, does the pain just come at once, or do we have signs that show before now, of course, the pain becomes more severe?
Okay, so let's talk about our commonest cause of low back pain, which is muscular strain. So it normally comes as from an activity that you've done, which you've talked about. Either you've sprained by lifting something heavy, or you've stood for long or sat for long, such scenarios. So there has to be a triggering effect for a muscular sprain, especially maybe if you're doing gym and overlifting. So there has to be a triggering effect. And then the next thing is pain in your back. So they normally say the pain runs from the central part of your back going to the side, like the posterior aspect of your waist. That's the commonest symptom. And then the pain is worsened by when you try to bend, because remember, we've said that it normally puts your back very stiff when your muscles are taut. So any activity you try to do will cause pain. So when you try to bend, your pain will be severe. You'll find some patients, when they try to walk, they're very stiff. You'll see that they have a very stiff gait because they're not able to be agile, as opposed to when your muscles are relaxed. That's for the muscular strain back pain. Then you have the degenerative back pain, commonly the disc disease. So either like a disc degenerative aspect or a disc prolapse kind of scenario. So such patients will have what we've talked about, the radicular pain. Radicular pain means you'll see your pain comes, you'll feel the pain comes from your back, moving down your leg. So it will go to, maybe to your toes, or to your ankle, or to your knee, or to your thigh. So it just depends the level of the disc that is involved. And we'll see such patients, their symptoms are worse at night, because during the day you are distracted with activities and all that, but at night, because you're relaxed, you're at bed, in bed rather, that's where your symptoms are more. And such patients, they come complaining, Daktari, I have taken Panadol, I've taken what, but it's not relieving pain, because nerve pain is different than muscular pain. There's also this, it's called lumbar stenosis, still caused by degenerative changes, or there's also some joints here at the back called the facet joints. So meaning such patients, when they walk, they get something called neurological claudication, such that the longer you walk, the more you're feeling your nerve is getting more compressed. So you prefer to stop and bend over. It's called like a shopping cart sign. Like you know how you lean over a shopping cart when you're going to the supermarket. That's how a patient. That's how they find relief from the pain. That's called your claudication. It's very common in advanced disc degenerative changes. And such patients, yes, they need to see a doctor for that. Yes.
All right. And speaking of course, seeing a doctor, for many patients that you've described, do they come to you when the pain is still less severe, or the most patients or cases that you look at are those that are already in the next stages?
So the good thing about our current society, patients are more aware about their, or patients are better in their health-seeking behavior. So you'll see that patients will come to you with a muscular sprain. But of course, with the older generation, our parents and our grandparents, their health-seeking behavior is not as good as the millennials, the young ones, So they normally tend to go to hospital when it's an advanced stage, where you call now you've caused lumbar stenosis, such that there's not much you can do. But good thing is, for the young population, they do health-seeking behavior very well.
All right. I think we'll be taking a very short break. Of course, now when we come back, we'll just be looking at the diagnosis. Of course, when someone comes to you, how exactly you diagnose them. Of course, as we look at the solutions of this. Of course, in studio, I'm with Dr. Jacqueline Mwema from PCEA Kikuyu Hospital, and we are looking at how you can manage back pain. Of course, we've looked at the skeleton or the structure or anatomy of the back pain. Of course, just looking at the risk factors and what are the signs and causes of this lower back pain. So we take a very short break. When we come back, we'll be looking at the diagnosis, as I said earlier, as well as trying to find solutions to this.
Katika ulimwengu wenye kasi na muda unaokwenda upesi, tunakusihi ujitulize kwa muda, ujiunganishe na upate kitulizo ndani ya kumbatio la upendo.
God of Bethel has been my God all those years. He cannot bring me this far to let me down.
The name of the Lord is a strong tower. The righteous they run unto it and they are safe.
Ukitembea na Mungu, mambo yote yanakuwa possible, yanawezekana.
Pamoja tuzame katika vilindi vya imani, tumaini na kuimarika kiroho.
Whatever was rightfully ours that the devil stole is going to come back to us.
Live in the sunshine, my brothers and sisters, whenever you face trials of many kinds.
Moto moto injilie. Moto moto injilie.
Kila kila siku ya Jumatatu hadi Alhamisi saa 3 usiku. Jiunge nasi katika kipindi cha In His Presence, uichochee nafsi yako kiroho.
Well, welcome back to our topic of discussion, or to our program this evening, where we are looking at how you can manage low back pain. Of course, in studio, I'm still with the expert, that is Dr. Jacqueline Mwema from the PCEA Kikuyu Hospital. Of course, one of the hospitals that provides solutions when it comes to problems to do with your bones, muscle, and of course, the conversation that we are having this particular evening. And just to remind you once again that this program is coming to you courtesy of the PCEA Church Health Week that has been running from Monday, and of course, the climax will be on Sunday. And all through, we've been informing you on matters to do with health. And today, we are looking at how you can manage lower back pain. Of course, if you're just joining us, you can follow us, that is on Facebook and YouTube at CAC TV Kenya, and you'll get to understand more about what we've been discussing. And now, Daktari, before we went for break, of course, we looked at the telltale signs of the lower back pain, but let us now look at what exactly will make someone come to you as an expert, or how severe can the pain be for me to come to you now for the checkups.
Thank you, Ida. So we've talked about the commonest pain, which is a muscular sprain. We've talked about the degenerative pain. It's important to note, in some of the degenerative conditions, including lumbar spine stenosis, or maybe what I haven't mentioned, Cauda-Equina syndrome, there's some what we call flags, red flags, that help us determine how severe or what should you be worried about in low back pain. Because in just a basic muscular sprain, you're not that worried about the patient. The patient, in 80% of the time, they'd recover. But in what you call the red flag signs, maybe with patient with history of trauma and then comes to you with low back pain with either radicular pain, which is pain moving down your leg, or a patient who comes to you with weakness of lower limb. You know, we've talked about the nerves that come from the spine, from the spinal cord moving down your legs. So if there's compression, there's severe compression of your nerve, and the nerve supplies the muscles and the skin of your lower legs, of your lower limbs, you get weakness. So patient will come to you saying, I cannot move my legs as I used to before, or I cannot walk without support, without aid, or I'm unable to walk completely, I have to use a wheelchair. So those are some of the red flags, yeah? Or maybe you've lost control of your urine or your bowel motions, you're not able to control. In such a patient, then you wouldn't dismiss. Those are red flags, and these are patients who need to be seen urgently in hospital for management.
And now, of course, that leads us now to diagnosis. How do you diagnose these? How do you now look at this patient, or what are some of the checkups, of course, that you do to this particular patient for you to determine now the management and treatment of them?
So the most important thing when you're trying to diagnose back pain, or how to categorize the back pain, is getting history from the patient. You want to understand how severe is your pain. Is it pain that is impeding you from doing your activities? Is it pain associated with nerve involvement? So history is very important. You also want to find out the type of job the patient is doing, such that to know is it what is triggering the pain. The next thing is to actually examine the patient, because that will help you decide what type of investigation you'd need to help diagnose the patient. So you'd see your doctor is trying to examine your muscle strength, your muscle bulk, your reflexes, before determining what investigation to do. So remember, we said our most common cause of low back pain is muscular sprain. So you can actually diagnose this in the office without actually going for any investigations. In our setup, mostly it's just imaging. Okay. So with muscle sprain, you just diagnose it in the office, just by palpating the back, by looking at how straightening your leg, does it cause a sprain in your back, something like that. So one of the commonest investigations we normally do is a radiograph. That's an x-ray of your back, best done when the patient is standing upright, because that's when you're loading your weight on the back. So with that, you'll be able to see if there's any deformities in the back. In a patient with muscular sprain, you'd actually see our curve, which we've talked about. The lordotic curve is straight. So on X-ray, you'll see it's a very straight X-ray, so you'll be able to make your diagnosis. Okay. In some of the degenerative changes, like it's called listhesis, when you have a lumbar spine stenosis, you'll see one of your vertebra is on top of the other, like it translates against the other. So these are some of the important images that will, and it's actually affordable. So we advocate, before running to the expensive images, at least have a basic imaging first. You know what you're working with, how where you're starting from, and so that you can make a decision. Do I need to advance further, or is the radiograph enough? In spine surgery, another important imaging is MRI, which is a magnetic resonance imaging. So it's usually quite expensive, so you'll find patients a bit hesitant to it, but it's usually very important in diagnosing back pain, especially for what you call the chronic back pain that has been refractive to medication and other forms of treatment. So for the radiograph, that is the X-ray, will focus on the bones. So you'll only see bones on the X-ray. You'll not see the disc, you'll not see the nerves. Okay. But with your MRI, it focuses on soft tissue intensity. So you'll be able to see your disc very well, you'll be able to see your spinal cord, you'll be able to see your nerves. So if there's a disc prolapse, this is now one of the main investigations for diagnosing disc prolapse. So you will see the disc very well compressing the nerve, and you will see that it will correlate to the patient. So the patient will come telling you, I'm feeling pain running down my right leg. So in your MRI, you will see the disc is compressing the left side. So it's usually inverse. So those two are the main investigations that are common in low back pain and in lumbar spine disease. But there's some investigations that can be done, like it's discography. Basically, this is more advanced, where you just use dye inside your spine, so that you look at the disease in your joints, in your posterior joints. These are the facets, and looking at the disc disease, basically. But the radiograph and the MRIs are the main main investigations that we normally use.
That you do. Okay, now with everything that you've explained, of course, I want to assume it will depend of how these particular investigations that you've done look like. But earlier on you spoke of these people that will come to you, I have taken a painkiller, I have taken this and this, and still the pain is still there. Before we look at now the treatment and management, what is the danger of me using painkillers? Will they worsen this, or what are some of the dangers that this can lead to your lower back and even to your general health?
Of course, everything has a good side of it and a risk and a bad side of it. Yeah. So if I go to the pharmacy, buy some paracetamol, buy some Brufen for my pain, if it's a one-time use, that's fine. But you know, if you keep taking it for a long time without a proper diagnosis, you don't even know what you're treating, First of all, you'll be frustrated because maybe you're not getting the relief you deserve because you're not taking the right medication. And of course, with every medication, there's some risks involved with the medication. Commonly, especially for the common medication we take in pharmacy, like your diclofenac, your paracetamol, it can cause some injuries to your kidneys, to your pancreas, and also some abdominal irritation. So this medication should be taken for certain duration of time to prevent damage to your organs, and they should be advised that should be prescribed by a medical practitioner.
Right, now let us look at now the management and treatment. How, of course, with all the problems that you've spoken of, how do we treat this? Of course, now first of all from an expert's point of view. Yeah.
So back to the commonest cause of back pain, muscular sprain. We've talked about the risk factors. What are the risks in your day-to-day life that will cause you back pain? So first thing your doctor will do is find the trigger. What is the trigger that's causing your back pain? Is it that you travel for a long time, bumpy roads? Is it that you lift very heavy objects? Do you bend a lot in your day-to-day life? Do you stand for a long time? Do you sit for a long time? So once you find the trigger, then you find an alternative on how to navigate past the trigger. I know you can't tell someone to stop doing their job because that's your daily living, but you can find alternatives to how to do the job. If your job involves you standing for the whole day, then you'd recommend maybe take breaks in between, take a walk, have a sit, then get back and continue your job. If your job is to sit the whole day, sit for maybe like an hour, stand up, walk for about 10 minutes, come back. And such and such. If your job involves heavy lifting, maybe you can carry in small packs, just distribute the weight. And then another thing we talked about is the overweight and obese patients. So once we see such patients, number one thing is to advise on weight loss, at least 5% of your body weight. You'll see improvement in your symptoms significantly. Once you've done the lifestyle, basically your lifestyle modification, then we come to medication. So muscular sprain, your muscles are in spasms, they're basically spasm. So you want to curb that. So you've already taken away the trigger, now you want to treat the spasm. So we give muscle relaxants to help relax the muscle so that at least you're able to be comfortable. You've tried this, patient has tried this, has taken care of the triggers, has done the muscle relaxants, but still comes back to you with pain. Next thing is to actually do physiotherapy. You send the patient to physiotherapy. So what physiotherapy does, they actually target the muscles. So they use their hands to try and relax the muscles. They can also use sound waves, ultrasounds to try to like send sounds to the muscles to kind of relax. So you'll see such patients on the day of physio, they've been so much pain, but by the end of the day or by the following day, their symptoms are much improved. And then there are some exercises you're given to do at home after the physio that will help strengthen your core, to help reduce the frequency of your low back pain. So that's for the muscular sprain, which is the commonest finding. Now, when it comes to degenerative source of back pain, same thing. We'll try medication first. So we'll give you painkillers with a muscle relaxant if needed to help with the pain, the muscular and maybe the disc part of it that will cause pain. But remember, such patients tend to have a lot of nerve pain as well, the radicular pain that we talked about. So we also offer some medication that will help confuse your mind, basically, to ignore the pain. So you'll find that we normally use some medication that are used in some neurological conditions, but are very helpful in that radicular pain. But this is also beneficial to have concurrently with physiotherapy. So such a patient has done physio, has done medication, maybe for 6 weeks to 3 months, no improvement. The next thing would be actually to inject your back with some medication to try and reduce the inflammation, and so basically it's a steroid that will help reduce the inflammation and relieve your symptoms for up to 3 months. So the patient at this time can also continue with physiotherapy to continue strengthening your core muscles and all that to help with the symptoms. Now, the last line of defense is surgery. But remember, surgery is not for the muscular strain, but for the degenerative kind of back pain. You'd never find a surgeon operating for muscle spasms, but for degenerative back pain, once you've stretched your conservative management to as much as possible, now surgery comes in. So which patients undergo surgery? So these are patients with chronic back pain with a cause, with either significant nerve root compression, or with, we talked about if a nerve is compressed for too long, you lose power in your legs, you lose the muscle power. So such patients are also warranted for surgery. But there's a patients who require emergency surgery. These are patients with something called Cauda syndrome. We talked about Cauda equina, which is the horse tail, compression of the nerve roots, that's from the lower back. So these patients are those ones who present with pain, low back pain for a short duration, with weakness of the lower limbs, with loss of bowel and bladder control. So such patients need to be decompressed immediately or urgently. Failure of which, despite the time you decompress, the recovery is not usually to 100%. So those are the how we normally manage our back pain. And of course, after surgery, patients will still require physiotherapy. And commonest, best cheap physio you can do is actually walking. So another thing I didn't mention is patients with especially the chronic back pain, we encourage them to walk as much as possible. That helps you to move your muscles, move your back, make you more agile. So it also helps with the pain.
All right. Thank you for that explanation. I'll just take you back to the diagnosis a little bit, because I've not had you put a name to now the lower back pain. And of course, especially with the elderly people, with the old, of course, our parents and all that, every time they'll feel pain. Of course, the issue of them diagnosing themselves, where since a friend of mine felt this pain and then they said it's arthritis, then mine could be arthritis. For lower back pain, is it associated in any way with arthritis, especially for the old age, now that you told us it's also a risk factor for this?
So in layman terms, yes, you can call it arthritis, but basically it's what we've called degenerative lower back pain. However, it's called spondylosis. Spondylosis is the arthritis of the back. Basically what happens is once your disc degenerates, it makes your bones now come together. They're rubbing against each other, so, and then the joints at the back here also degenerate. So you'll see on your x-ray, you'll see several tiny horns on your bones, which is indicative of degeneration. Spondylotic changes is what it's called. So a patient, elderly patients, seeing that on x-ray, depending on how the patient presents, will determine should we be alarmed or should we accept it as age-related changes to the back. Yes.
Okay, thank you for that, and of course thank you for explaining that. Now let's go back to the surgery where we left it at. Of course, you've tried all interventions and now you've decided that it's surgery. How do you prepare this particular patient, and what's the success of this? How soon will they go back to their daily activities?
So one of the most important preparation technique is obtaining consent. You need the patient to understand exactly what you're going to do, what the patient is going to gain from the surgery, and the risks involved with the surgery. And one of the commonest questions is, will I be able to go back to how I used to be? So it depends with the diagnosis you're working with. If it's basically just a disc prolapse that you're dealing with, maybe in the middle-aged population, they do so well by just removing the disc. It's called a microdiscectomy, just removing the disc to remove the compression of the nerves or of the cord. So they do well. But then there's also, in some instances, especially the degenerative disease, where you can have some instability in the back due to degeneration. So these patients would require decompression, like releasing what is compressing your nerves, but you'll also need to fuse these patients. Fusion means you're going to put screws, screws in the pedicles. This is the pedicles, and attach them with rods. So in the initial stages post-surgery, this patient will complain of stiffness, because you know you've changed what used to be a very mobile joint to a very stiff construct. So such a patient will not do activities that they used to do before. But what does a patient gain? The patient will be free of pain. The patient will be free of the radicular pain, especially if you've accompanied that with decompression. The next question will be, how soon will I go back to my day-to-day activities? It depends with the surgery you've done. If it's a basic discectomy where you're just removing the disc that's compressing the nerve, the patient normally returns maybe within 6 weeks to 3 months. And it just depends on how the patient progresses with physiotherapy, and the main physiotherapy is walking. With fusion, it takes a bit longer because, again, you've reduced the agility of the back, but you've taken care of pain. So patients may take 3 to 6 months, depending on age, depending on the levels of fusion that were done. Yes.
All right. Of course, once again, thank you for that. You've spoken of after surgery, one of the issues will be maybe stiffness. Is there any other? Because you've said you're removing the disc. What exactly are you replacing the disc with? And I don't know whether it's a myth or a fact. You'll just clarify that. I've attended and, of course, seen a surgery that is for knee. So do you replace this particular disc with can I say a metal? And now the myth and the fact comes where the patients probably, they'll be complaining of pain, especially during different weather, maybe during the cold. Is that one of the things that they'll be experiencing? And probably, is it within the 6 months or even after?
So that's a very interesting question. In our setup, basically in Kenya, we do not, once we remove the disc, we do not replace it. Because remember, the reason we're removing the disc is to remove what is compressing your nerve. So you do not want to put something there that can still later on cause the compression that was there before. You cannot do multiple, like maybe removing one disc is enough such that you won't cause instability in the joint, so you'll not feel a difference basically with that disc that you removed. With regards to the fusion, I think about feeling the effects when it's cold. For back implants, not as common as for joint replacement implants. But there are some people who are a bit more sensitive, so yes, they can feel some sensitivity when it's cold, and it's usually just due to contraction of the implant when it's cold. Just like how you can have vasoconstriction, you can also have constriction of your implants.
All right, thank you. Now, just in summary, or probably just to our audience, a word like a parting shot to our audience when it comes to a lower back pain. You've dealt with so much patients. Of course, you've seen so much patients, those that are less severe, those that are severe. What would be one thing that you'll just advise our audience in terms of managing this, and most importantly, just preventing this from happening?
So low back pain starts with you. How to manage low back pain starts with you. The main thing is just to adjust how you do your activities. From your 20s, you shouldn't do the activities, your normal daily activities like you used to when you're a teenager. So adjust how you do activities to prevent the frequent visits to a doctor. I think that's an important thing when it comes to back pain. Another thing, once it starts, getting a painkiller from the pharmacy the first time is acceptable. But keep doing it without getting a proper diagnosis from a doctor or proper prescription is not advisable. So maybe the first time, that's okay. But then once it gets recurrent, I'd advise you to seek medical advice.
Okay, and another opportunity just to, of course, as we are providing solution, I know Kikuyu Hospital is one of the hospitals that, of course, deal with now the orthopedics and the bones a lot. Just tell us, or just tell our audience probably about your orthopedic unit.
So orthopedic PCA Kikuyu rehab unit has been in operation since the 1990s. And it was started to help the population to deal with basic orthopedic conditions, and it's a referral hospital for orthopedic conditions. So we deal with any orthopedic condition, either from your spine to your degenerative arthritis, your knees, your hips, and sports injuries. So we have outpatient clinic which runs every weekday from 8 to 4. We run theater every weekday from 8 to the time the list ends. We have a very state-of-the-art prosthetic shop where we design and design prosthesis for patients. We have a state-of-the-art physiotherapy offering physio services to the patient. And we have an inpatient department where we handle our theater patients. And yeah, basically that's our orthopedic unit. So I'd like to welcome our viewers to come visit us for any orthopedic problem. We'll be there to help.
All right, thank you so much for that. Thank you for informing us on that, and most importantly, for just helping us, of course, understand all this. And the most important thing is, of course, how we can prevent this, and of course, if you already have that, how you can manage that. All right, thank you so much to you as well, our viewer, for tuning in. I hope that you've been able to learn on how you can manage back pain, and most importantly, how you can prevent that as well. That was Dr. Jacqueline Mwema from PCA Kikuyu Hospital. That is on issues to do with orthopedic, of course, the bones and all that. So once again, asante sana for tuning in. This program was coming to you courtesy of the PCA Church Health Week. My name is Aida Muzati. I'm wishing you a blessed and, of course, healthy, peaceful sleep.